And we're live. Good morning, good afternoon, or good evening, depending on when and where you're watching. This is the Healthcare Leadership Show with Marion Spears Carr. That is me. We are so glad to be back for another episode, and just glad to be here with my returning guest, Cheryl Dalton Norman of Conduit Health Partners. And I invited Cheryl after our last show. And if you did not see our previous show, I'll put the link in the comments a little bit later, let you go back and check it out. Cheryl and I had a massive and amazing conversation around the work that she's doing at Conduit Health Partners and with organizations across the country. And it is amazing. But I wanted to have this topic. I wanted her to come and talk about this topic today because, one, recently we got experience personally, but also how important it is. For those of you watching the Healthcare Leadership Spears Carr, and I work in the world of leadership development executive search. I'm a founder of a company called Inflow Executives. We work with healthcare organizations also across the country in a lot of different capacities, from talent, but also development. And almost all of our clients are patient facing, a lot of hospitals, community hospitals, big hospitals, et cetera. Today's topic and what we're talking about is the emergency department as a default, the causes, cost, and closing the access gap, and why EDs across the country are overwhelmed with patients. And Cheryl, welcome back to the show. Thank you for agreeing to talking about this topic. Please introduce yourself to the audience who may be new for the first time or didn't get to hear your previous discussion with me. Glad to have you, Cheryl. We were laughing so much before we went on the air, I almost lost track of time. So thank you for coming, Cheryl.
Well, thank you for having me back. I had a great time last time, and I'm looking forward to our conversation today because it's so important, both personally for individuals, but also from a health system perspective. I've been a registered nurse for 43 years, and I'm the founder and president of Conduit Health Partners. We are affiliated and owned by a large faith-based health system in the United States, Bon Secours Mercy Health, but we serve clients across the country from coast to coast and north to south, really helping organizations solve problems around access, nurse triage, transfer center, those types of things. But today's topic is very near and dear to my heart, having had leadership responsibility for many years over emergency services delivery. So excited about our conversation today.
Well, I am as well. And this is something I've been paying quite a bit of attention to, particularly in the rural and community markets where the EDs are the first and oftentimes the only point of care for in the minds of the patients and the people who live in those communities. But first, before we get started, I would love, if you're watching live or if you watch the replay, please right now post in the comments. Let us know where you're watching from. This is important for the reach of this show. When you do that, it tells others, hey, there's this event going on called the Healthcare Leadership Show, and it helps us grow, but it also helps me understand who we're reaching. And one thing that would be really helpful too, and I've not asked this before, but let us know what your role is. You know, we want this conversation to be connected and interactive. So if you're watching live, please post in the comments. Let us know. We'll be able to see those comments. And if you have questions for Cheryl later in the show, let's put those questions in the comments well, and we'll bring them up. Cheryl, one of the things that you and I have talked about is really what – can you lay out a little bit about what the problem is that we're facing here? Because I've looked at a lot of different statistics out there. There's I saw roughly half of all emergency department visits in the U.S. are classified really as non-urgent or semi-urgent. Mm-hmm. But what, for the audience sake, what's really the scope of the challenge out there? And you and I are going to talk more about how do we solve this problem or how healthcare systems can solve this problem. But can you set the table for what the challenges are right now in the marketplace?
Yeah. So just some data, and this is from AHRQ, really, research-based, and this was presented in September of 24, looking at 2021 data. But in the United States, there were 107.4 million treat and release emergency department visits that cost about $80.3 billion. So this is not treat and then we admit you, but this is treat and we sent you home. So if we said, okay, half of those, just half of those might have had a better place to go than the emergency department, what kind of difference would that make for people, for health systems, and for the people who truly need emergent care? And, and it's not about keeping people out of the ED. That's not what it's about, but rather it's about putting them in the right place for care or connecting them with the right resource to figure out, do I need to go to the ER? Do I need to just go to the urgent care? Could I wait until tomorrow to see my primary care provider? What should I be doing for myself in the interim? Those kinds of things. And those are things that are not made readily available to the public, in my opinion, in my experience as well. And, when we think about why people, and you and I were talking about this even before the show, why do people go to the ED? A lot of times they're just scared and don't have someone to talk to about whether they should go. Some is expedience. I want something right now, and we can talk more about that later. Some are true need. I do need to go to the ER. I'm having crushing chest pain. And then the fourth really can be habit. And those are four quick, and there are probably many other reasons, but those are the four that really speak to me right now.
And you and I could probably do a show on each one of those topics. And one of the things that you and I've talked about, Cheryl, and one of the things I've tried to accomplish on my show is not just to point out the problem, but offer solutions. So we're going to get into that. But first, I want to give a shout out. Again, if you're watching live, please let us know. Or if you watch the replay, post in those comments. We're always looking at the comments. Dominique Wells is checking in from Kentucky. Dominique, it's good to see you. I can't. Elia, how do you pronounce it? Elia. Elia. Is that it? Stanko is checking in from Ohio. Amanda is checking in from Nevada. Colleen's checking in from Ohio. And my friend, Dr. Joshua Gutman, is checking in from Atlanta, Georgia. Dr. Gutman is an ER physician who's also an advocate and expert in the world of using ultrasound, point of care ultrasound. Glad to have Dr. Gutman here in the audience and glad to have his insight. So if you're watching live, please let us know. So let's just jump right in, Cheryl. One of the things that you and I talked about in our previous show is about the work that y'all do. But tell me a little bit about, like, from your perspective, when we think about understanding the ED as a default, you talked about that a little bit, but tell me a little bit about your experience about what's the number one reason you think patients end up there, and when they probably didn't need to be there. You mentioned habit, you mentioned lack of access, and access is a big challenge. I mean, one of the things we've been talking about a lot too is the Rural Health Transformation Program funding that's going on. I just did a show on that a few weeks ago. If you're interested in that topic, please check that out. When we think about, let's define what we're talking about. What does habitual ED use look like? Let's start with that, because I think that seems to be a big portion of, it's like, oh, I got an ER. I mean, matter of fact, you and I talked about this on the pre-show. As a kid growing up, at the risk of sounding like the old man that I am, the only time that I went to the ER is because I had a gaping wound from something I did and had to be stitched up, or I had broken a bone.
Yeah.
Otherwise, we didn't go.
Yeah.
Talk about the habitual ED use and why that's been created in the marketplace. Again, we're identifying the problem. We are going to talk about solutions in a moment, but talk about that a little bit as well.
So habitual use, and I know Dr. Gutman is probably very familiar with this. These are the folks that are on a first name basis with the ED staff. It is, and I will say habitual use comes from a variety of reasons. And it really depends on where your hospital is located. So if you're perhaps in an inner city location, I had an ER that was located where there was a lot of homelessness near there. So often a lot of utilization by those who are unhoused and seeking food or shelter or other kinds of things, which is an ongoing problem in many communities. So there's that. There are also behavioral health issues for those who do not have ready access to behavioral health resources. And that's a whole additional show, Marion, about the real disservice to the people who need behavioral health resources and the challenges in getting those. And the ED is often the only place they can access that resource. And then there are those who are lonely or just, are just like, you know what? I want something right now.
Yeah.
I'm going to the ER. And we live in a right now society. And so in the absence of something else right now, or without a really strategically driven, and health systems have to be strategic in understanding. And what we help in Conduit is for organizations to understand who needs triage, who needs health resources. Is it your people who've just been discharged from the hospital but have no resources when they get home? So if something doesn't seem right, they're just coming right back in. We help folks understand who needs help and why do they need help. But habit is an issue, and we have to be strategic in helping folks find a better place.
Yeah, I'm curious for the audience, if you're watching live and I'm curious to see if you work in a hospital, work in a hospital system, if you have access to your ED utilization rates right now. I'd be curious if you post in the chat what you actually know what that number looks like in your community. In my show, for those of you who may have only seen the show the first time, we have people that watch this show all over the world. Really, I've guessed Europe and attendees, but all over, obviously the heartland of US. If you don't know my accent, I'm from North Carolina. I live in the mountain Georgia and live in a rural area myself. We're going to talk about that in a moment, but access is a challenge. If you have access to your rates, your utilization rates, please post them in the chat. We'd like to hear from that. When you think about, Cheryl, let's talk about now. Again, we're continuing to talk about the problem because I know I want to get into the solutions. You mentioned earlier about the cost. It's crazy, but let's talk about what this actually costs. Tell us a little bit more. And tell us about what ED overuse cost the healthcare system and how that's taxing on their resources as well.
Oh, yeah. Well, there's all kinds of costs. So if you were just to say an average ED, you're not coming out of the ED without a bill of about, I'd say $5,000.
Yeah.
On average. Yeah. And so again, it's costing payers. It's costing individuals, it's costing the government, it's costing individuals. And when people aren't able to pay, it's ultimately costing the health system. So there's costs for everyone wrapped up into that. And if you think about what if we had enough PCPs locally for folks to be able to readily see them? What if we had adjacent urgent cares so that people could utilize that? What if we offered nurse triage, go figure, where people could call, have a conversation, understand, and get advice on what they needed to do? All of those are such low cost options that really make a difference. But I'll tell you, my son works for a major health system in Texas, and he shared this with me this morning. We were talking, and he said, I did research for our COO and found out that patients who were admitted through the ED their general satisfaction, their patient experience scores were lower. And I'm like,
Wow.
well, I mean, we know this.
Okay.
We
Yep.
know this because if you come through the ED, likely you are seeing all kinds of stuff. You're hearing all kinds of things. Often because of overutilization, you're having to wait for things. We use our EDs and they are used in such a way that it doesn't drive an amazing experience for the people who really need to be there.
Yeah.
And so I applaud this particular COO for being really thoughtful and thinking about how do they address ED utilization as a strategy for overall patient engagement and experience.
Yeah, and to your point earlier, Dr. Gutman is weighed in, and thank you. This is so important. I know Dr. Gutman works in, by the way, one of the busiest ERs in Atlanta, if not the busiest. He goes, it both, to your point, it's the first aim basis. Also, what you might touch on is patients just make it a habit of coming for any issue. They don't consider, I love this comment. This is exactly what you're talking about. They don't consider or don't know if alternative pathways even exist.
Yeah.
To your point, that's where the work needs to be done. Coming to the doctor to them often means going to the ED. That's just their route.
Yeah.
So yeah, you just spoke to that, Dr. Gutman. Thank you for those. Thank you for being in the chat. This is exactly what I created this show for, Cheryl, for these kind of conversations. But talk about that. What can we do? Let's just go right to it. Just change. It's almost a cultural choice, right? This is what I'm going to the doctor, which means they're driving to the ED.
Yeah.
Talk about that. That's speak to that if you don't mind.
Yeah. So I think there are a couple of options. And in my experience, there's a lot of work that you can do before people come to the ER, but we often assume people understand the pathways, or they understand what they should do. And one of our large clients in Texas, as you know, we're the front end of calling the doctor's office. So I think often, if you're calling in after hours, you're going to speak to, if you have a medical need, you're going to speak with a conduit triage nurse first to help do that. So make it easy. Don't make me struggle. Don't make me look for a number. Don't make me work for it. If you make me work for it, I will take the easy button and I'll go to the ER. So we have to make it easy and known for people to be able to access something different, whether that be triage, whether that be their PCP, or, and again, what's open 24 hours a day? The ER or triage. And even urgent cares and PCPs aren't open 24 hours a day. So we have to make it known. But then for ER leaders and health system leaders, looking at and talking with our patients, having strategic programs in place to address overutilization. Not a punishment, not a, you shouldn't have come to the ER. That should never be the conversation. But we care about you. We want you to have an easier access to care. What can we do to get you perhaps established with a clinic, even if it's a community clinic that is funded, by a church or some other philanthropic organization or a PCP? What can we do that gives you an alternative? Because if we don't give you an alternative, acting like you shouldn't be there is not the solution. And shaming people is not the solution. So we have to have a plan and help people have a better solution.
I love that. And checking in the comments, Kelly is checking in from Georgia. Kelly Fraser Johnson. She's a North Carolina transplant in Georgia too. So go Kelly. Glad to have you down here in Georgia. And Ragu's checking in from Michigan. He's a healthcare executive. Has been in my network for a while. Just glad to have him. Cheryl, so talk about this with us for a minute. So if we think about a healthcare organization that's in a community, regardless of what the size of the community is, a lot of people in my network are hospital operators, across the country and in a variety of ways. If they start to look at their utilization rates, really take a hard look, which we just asked in the comments post, what's the first thing they can do when they look at that? What's the first step in addressing this? I mean, obviously it's not going to be fixed overnight. And to your point earlier, we've conditioned ourselves to expect things right now. One of my mentors, he says that we've conditioned ourselves to want everything now, perfect and free.
Mm-hmm.
That's how we've conditioned ourselves, or almost free, right?
Yeah.
So that's a change of mindset that we're going to have to change. But what's the first thing a healthcare organization or a healthcare operator could do to, one, look at the problem, but then what's one thing they could do first to start the process?
Yeah. Well, one of the things in ERs that I've had responsibility for that we've implemented is a daily ED stand-up that has your facility president, your facility CFO, your facility COO, CNO, and your ED leaders every day. ED stand up to understand. First, you have to understand what's happening, and you have to make it a priority, and presence shows priority. So I say that, but then understanding what's your ESI, your severity index showing you. Do you have a lot of 4s and 5s, ESI 4s and 5s, which are your lower acuity, that could be managed in a different way? And then, I mean, you have to dig into the data every day, all the time, to understand who's showing up for what diagnoses. Then you can strategically consider, what are the things that we need to do to help with this? Do we need to have a nurse triage line that we share with everyone? And again, we're not trying to have EMTALA violations. We're not trying to send people away, but we're trying to give people options. And we need to understand who is showing up. And then, understanding why, I think is really, really important. So first, healthcare executives need to show up in the emergency room to understand what's going on, look at the data, understand their severity index spread.
Yes.
And then understand what are the diagnoses that are coming in those 4s and 5s, and then strategically ensure there are other options, not just other options that are subtly known to only a select few, but are widely known and advertised to the public.
Yeah, I love how you walk through that and how that process, because I mean, when you think about that, that's so important to understand. What you and I talked about in the pre-show. Sometimes I ought to just go live in the pre-show. That's what we're gonna do next time. I'm just gonna go live, and we're gonna have the pre-show just going, because Amanda was on with us for a moment, and we just went down a bunch of different rabbit holes. But to the point, we talked about this very thing, is like, are we solving the right problem? We have to understand what the problem is to do that. That's exactly on point. I think one of the things we're working on, and to your point earlier around how patient satisfaction scores are lower for people who have come through the ED for inpatient and been admitted. We're seeing that early. We're working with some organizations right now on using the gratitude training that you and I've taught, that I'm working on with some partners, on how to improve patient satisfaction scores. That's the early iterations of that. But one of the things we were looking at was what departments are the least likely to have a nurse voted on to get the DAISY Award, which is the award for patients promote. We had a great experience with this nurse, and this nurse did such great work. And we looked at just some simple short data. We don't have a big sample size, but there are very few ER nurses ever nominated for a DAISY Award.
Yeah.
Why?
Yeah.
Because the patients are not having those experiences where, oh, wow, that was a great experience.
Yeah.
So talk about, and we didn't talk about that, but that just hit me in my brain just a moment ago. Talk about how having this kind of situation for nurses and organizations for the patient exact that they're, I guess maybe go back. What do you see from a patient satisfaction perspective for people that have dealt with a nurse in a triage situation? What does that look like? Maybe that's the question. What are patient satisfaction scores look like? Do you have a feel for how patients are once they have a triage type experience we're talking about? What does that look like in terms of their perception on the kind of care they got? I'd love to hear about that.
Yeah. So I think there's the ER experience and then there's the telephonic triage experience. What we find in telephonic triage, which is very high satisfaction engagement because we're meeting them where they are in the moment. Let's move over to the ER. You have individuals, if they are in true crisis, the nurse, I mean, you've got a team coming in, running and gunning, getting it done, getting patients to where they need to be. So a longitudinal relationship doesn't develop. It is an in the moment relationship. Mm-hmm. So for those who are surveyed just about their ED experience, and you could have high nursing scores because they're only judging it from there. When you look at a DAISY award, I would say, and I'm saying this from my experience, I don't have data to back this.
Yeah.
My experience on the floor in the hospital or in ICU or wherever hospice, wherever I might be, is going to have more time. I'm going to develop this relationship with you differently than I'm snatching you from the jaws of death here in this 2 hours we're together in the ED.
Yes.
So it's just a different relationship. It can still be, a really good relationship, and it should be a caring, and I should know that you're concerned for me as a nurse while you're caring for me. It will just be a different relationship though.
That's awesome. And thank you for, and I know that was a digression from where we were. Leah points out the Conduit team does a wonderful, she's one of your partners out there. She's one of your clients or partners. Conduit team does a wonderful job reducing unnecessary ED costs while ensuring safe patient care. They saw a 33% reduction in year one. Mm-hmm. And obviously she's giving you a shout out. Great to partner with you and highly recommend it. Talk about that. Let's talk about how that 33% reduction in year one happened.
Yeah. Well,
thank you, Leah, for that.
She's a great partner. And we work with a variety of different types of organizations. This really was a program for a health system employee base. So their health plan, about 60,000 lives in this health plan. And what was noticed was people were using the ED in the middle of the day during the week for non-emergent care.
Yeah.
And because it was easy. And we often think that people who aren't healthcare professionals use the ED more than healthcare professionals. That would not be true. Healthcare professionals are just as guilty as everyone else because we know, hey, we'll just run down to the ED or I get, that kind of thing. But what we did in partnership was with Elia and her team was put together a program where if you called nurse triage first for a non-urgent condition, I'm not talking about chest pain or, I can't breathe, but for a non-emergent condition, if you called us first, your copay was lower. And what we found was, and at first you could have heard the screams of all the employees going, oh my gosh, you're gatekeeping the ED. And within like a week, it was crickets because everyone was like, oh my gosh, thank you. Thank you. Because you helped us get what we need. You weren't trying to keep us out of the ER. You were trying to get us to the right care and you helped us. So it was it continues to be a great program, but the majority of the change really came in that first year. And again, it's about learning that there's other routes, that I have other access. I don't have to go to the ED.
Yeah, and that is such a valuable asset for an organization to have, and being able to educate patients so they don't have to go that route. Dominique's checking in the comments and is sharing a lot of information around that. One of the things that she shared with us is that in her experience, our experience, many patients ultimately do not require, to your point, a visit of any type. They simply require guidance and reassurance that what they are experiencing can be treated safely at home. And I think that whole thing is like people are scared, right? We've talked about that, right? They're scared. And let's face it, we've come through COVID, the whole COVID era where we were bombarded with fear, right? That was ultimately, and rightly so in some ways because it was unknown. The unknown is scary. Cheryl, I knew we were going to always run long, and we're right at the last of our time together today, and we'll do. You know what? We may just start a series with you in Conduit. I don't know. Employer executives in Conduit will be some kind of. We'll do something. But Cheryl, tie a bow on this. Bring us back to full circle. How can they work with you? That would be one thing, and then secondly, I guess. And you made a point to leaders and operators what they need to be looking for, but any last pieces of wisdom that you can share with our audience? And by the way, if you've watched this live or you're watching the replay, please share this with your network. Please share these conversations. This is the whole idea of the Healthcare Leadership Show, is to scale our reach for our guests, for us, and for our community.
Yeah.
Cheryl, any last thoughts, and let us know, let the audience know how they can connect with you.
Yeah. So you can go to www.conduithealth.com and we are happy to work with you. I'm on LinkedIn, Cheryl Dalton Norman. But so we would love to help folks. And I think at the end of the day, I would call on health system executives to get involved personally, spend time in the emergency department personally, and see what's going on, and then create strategic plans that address the population overutilizing your emergency department. It's the right thing to do for others, and it's the right thing to do for your system.
Well, that's a great way to tie a bow on it. Thank you, Cheryl, for being on the show. Let's connect soon and talk about when we're going to talk again. Really enjoy working with your team. For those of you who are watching the show, please let us know in the comments what you thought. And if you enjoyed what you saw, please send it to your network. Stay connected with me. If you're not connected with me, as a first level connection, so you can be invited to other shows I have coming up. Going to be talking with a physician executive not too long from now, very soon, on gratitude, and he's an intensivist who works in an ICU environment. So that's a show coming up. We got some other things coming up. Cheryl, thanks for being on the show. If you're watching live or in the comments, let us know how much you like the show, and share it with your friends and share it with your network. Have a great day, and we will talk soon.
Thank you.